Hormone, it's a nice day for a white wedding. It's a nice day to start again. Wow.
What's going on, people? Welcome to episode 4 of The Art of Medicine. With me is the Doctor Who Cares, Michael Uphues. How you doing today, man?
Yes, my friends, it's good to be back at Sunshine Supply 352 Cavern Kratom Bar. This is our favorite place, Inverness, Florida. You guys need to come down. I'm telling you. The conversations zigzag off into a thousand, infinite number of directions. So, highly recommend coming down.
Believe it or not, we're actually recording 2 episodes back to back right now. So we just pretty much redid that same exact intro twice over.
That's what we love to do in our spare time, folks. That's what we love to do.
This episode is based on woman's bioidentical hormone replacement therapy. We just did an episode on men's
Bioidentical hormone replacement therapy. Yeah, we did. So we wanted to get into women's hormone replacement therapy. Again, I get about an even number of men and women coming to see me because this is such a hot topic. No, everybody knows about this now. Years ago, this was taboo to even talk about. But what the audience needs to know is that one of the reasons is the hormones that were used back then, especially for women, if you think about this, were things like Premarin. So Premarin is an estrogen from horse urine. It contains actually it is. It's what Premarin is from. And it contains over 30 different estrogens. And then they would use Provera, which is a synthetic progesterone. Well, here's the problem. So all these blood clots and cancers and things that we're hearing about were based on the fact that these were synthetic. These were not bioidentical. So when we talk bioidentical hormone replacement, people can now know, because the recent study just showed it. So bioidentical hormone replacement therapy is safe, it's effective, and it's also protective. So estrogen is cardioprotective, and I like to keep even men and women somewhere between at least 40, level of 40 to 60. There's two different types of estrogen receptors in the body: estrogen receptor alpha and beta. Estrogen receptor beta are more prevalent in the heart, and those are what are responsible for its cardioprotection. Estrogen is protective also to the GI tract, and this is one of the reasons that women actually have a lower incidence or risk of colon cancer than men do, because they have estrogen, and it protects the GI tract. Yeah, it's an interesting fact. Estrogen is also very efficacious for brain health, and this is why some of these guys that are on testosterone replacement and then they want to take estrogen, the aromatase inhibitors to stop from producing estrogen, is not good. It's not good for the brain. It's not good for the cardiovascular system. So you want to keep, and again, I try to keep guys somewhere around the 40 range of estrogen. So people will ask me, what is a cutoff for a woman receiving bioidentical hormone replacement? Well, typically it's about 10 years post-menopause or 75 years old. But to be honest, there's no hard and fast rules. Those are general guideposts. So I've had ladies come to me in their mid-70s. Obviously, they've been post-menopausal for much longer than 10 years. We start them, and they do just fine. So very important for women, because estrogen with progesterone, will also decrease bone loss, so it'll maintain, bone mass. Alzheimer's actually is worsened by low amounts of estrogen and testosterone. Estrogen, testosterone protect the brain, and estrogen and testosterone decrease beta amyloid plaques, which deposit in the brain, which is, again, partially responsible for Alzheimer's disease. B vitamins are always essential because you cannot make estrogen in the body without B vitamins. They're essential in order to make them. So that's how we start things off. I did want to talk about some baseline testing women should think about prior to starting bioidentical hormone replacement therapy. One would be a mammogram, baseline and every year, and also a transvaginal ultrasound. You want to make sure that there's no thickening of the endometrial stripe or, God forbid, an endometrial cancer, and then you're giving people hormones. So, in order to protect against that, we recommend those 2 tests, baseline. And there's other lab tests too, but the 2 tests would be a mammogram and then transvaginal ultrasound. And you never do bioidentical hormone replacement therapy on women that have had breast cancer or renal failure.
What is the reason behind that?
So, because if they have a breast cancer that is estrogen receptor positive, it's like throwing gas on a fire.
Oh no shit! You'll
Yeah,
just flare up that fucking
it'll
thing.
flare up. Yep. So you got to be very careful with that. Yep. You want to be aware of ladies that have polycystic ovarian syndrome and cystic breasts, like very, very dense cystic breasts, because, and as well as seizures. Estrogen administration can actually trigger seizures in women with a history of a seizure disorder. So it's something to be careful of. Women that are overweight, if they smoke, if they have a clotting history, they should be very careful, again, starting estrogen therapy. Smoking itself just eats up estrogen and decreases estrogen levels in the body.
So, if someone was a heavy smoker, an overweight woman, and they wanted to get their estrogen levels fixed, the first step is stop smoking.
Stop smoking and also get the weight under control, because the heavier you are too, the more estrogen is produced. So I would we talked about this in men too, that you don't just start them on testosterone. We first talk diet, then we talk exercise, then we talk about optimizing their metabolism, including their thyroid function.
Yeah.
Then we move on to the other, hormones that need to be replaced. In this situation, in ladies, it's typically estrogen, progesterone, DHEA, which is dehydroepiandrosterone, and also testosterone. Women need testosterone too. So it's fleeting amounts compared to men, very, very small amounts. But every single woman I have on bioidentical hormone replacement right now, I do have on small amounts of testosterone as well. And their husbands thank me, and you're welcome. You're welcome, because yes, they.
Ties right into sexual health. Right?
Into sexual health, absolutely, absolutely.
Awesome.
They're
awesome.
And with the estrogen, they don't have problems with vaginal dryness. And then, of course, when you add in the testosterone, the sex drive increases substantially. So they're wet and they're horny, which their husbands they thank me. That's all I can tell you guys. So you're welcome.
Wow, that's incredible. You learn something new every day.
Yes,
That's
wet and horny. That's all we want, ladies.
That's it.
That's all I do.
Amen.
We all like this as men.
Damn right.
So, and that's the one thing I wanted to talk about. So, I always love to have the couples come in if they're in a relationship, be it a boyfriend, girlfriend, or be it a married couple, because you want to manage patients' expectations of what they're about to embark upon. In this case, bioidentical hormone replacement therapy, which means, Ron, hormones don't fix bad relationships.
No.
This is the problem. So, you don't just think you're going to throw a medication at this or hormones and you're going to fix like a terrible relationship. You got to make sure they're both on the same page, and look, if they need to go to therapy to hash things out, it's a good idea before you go ahead and start this, because it certainly is not going to fix a relationship that's on the rocks.
And by that knowledge, hormones don't cause bad relationships either.
Absolutely not.
You could have fucked up hormones, still be in a fucking perfect relationship.
Absolutely. Yeah, no, that's a great point to bring up. Yeah, so I always love to meet the couples in order to kind of manage the expectations first. I just think it's a smart and important thing to do.
No, of course.
And keep in mind, like the word normal, when we say normal, like normal ranges of things, normal is, a risk factor for disease. What we're trying to do, as we said in previous podcasts, is we're trying to optimize. See, we're trying to push people's levels toward high normal or even a little bit above, to really dial in and optimize function. We don't want it at the low end. At the low end, you're not functioning at your highest level. So that needs to be talked about. So estrogen, if there's a decrease in estrogen, the number one complaint is vaginal dryness, far and away. They will talk about hot flashes, breast tenderness, and all that. Number one, though, is vaginal dryness. If you have a decreased progesterone level, number one thing, disrupted sleep. And when women have decreased testosterone, number one, decreased libido. So the three, with those three hormones, if you look at it, how do we know they're low? Estrogen, vaginal dryness. Progesterone low, decreased sleep or sleep disturbance. Decreased testosterone, boom, decreased libido. Just by asking those three questions where you're at, likely hormonally. And of course, the tests will always bear it out. And that's what we usually wind up finding out, is that all those things are low, based on just those particular signs and symptoms. So. Yeah. So one thing I wanted to talk about too is, so people say, well, if I go on there, are there any kind of, are there any risks or complications from bioidentical hormone replacement therapy in women? So one would be bleeding. Here's what happens. If you go on progesterone and they even miss one dose, you can start to bleed. If they continue to bleed, if you double the dose, typically that will go away. So that's number one. So low, if you stop the progesterone abruptly once you've started it, that can happen. You can get breakthrough bleeding from the vagina. Secondly is hair loss. And so hair loss is an interesting one to talk about because it really depends on the distribution of hair loss. If you see hair loss in the outside, the lateral part of the eyebrows, that will typically mean a low or underactive thyroid gland. It has nothing to do with the estrogen part. If women start getting a male pattern type baldness, which you can see this in polycystic ovarian syndrome, they might have too much dihydrotestosterone, which comes from having too much testosterone in your system. And it's being converted to DHT, dihydrotestosterone, which is a much more potent androgen than testosterone is. Too much hair growth, especially on the face, usually in a woman will indicate too much testosterone. You'll also see their blood pressure increase as well. Weight gain is kind of a soft symptom. That could be estrogen, especially if there's bloating. It can be from progesterone, like we see people that get the Depo-Provera shots. They almost always gain weight. And testosterone, sometimes the weight gain will come from either fluid retention or they'll start to actually increase lean body mass if they're working out. You'll get weight gain from that. But in the case of bloating, it's too much estrogen, and of course you'll know it's not from testosterone. If your libido is down, it's not going to be testosterone.
Yeah, okay.
It's going to be low test.
I do got a question though. In the men's bioidentical hormone replacement episode, we talked about a lot of young men suffering from low testosterone. Do you see any young woman suffering from low estrogen, or is it like a?
Yeah, absolutely. So and that's the number one. So the number one sign, that's usually around perimenopause or the menopausal time. Vaginal dryness, number one. Sometimes their moods will get labile, and then of course hot flashes, which is the vascular response. And so that's when you see that's what happens when you see the low estrogen. If the thyroid and the dihydrotestosterone are normal and there is hair loss, one other thing we always need to look at, and a lot of docs miss this, is you check iron levels and ferritin levels, which is your stores of iron. And the reason is, if you have low iron, that means you have less hemoglobin circulating in the red cells going to all the tissues, including the scalp. And what that can lead to is hair loss. So if you have hair loss that's unexplained by their hormones, because those seem to be normal, check a ferritin and see if that's not low. Typically it will be. It'll be a little on the low side. So that's always something to look at. So those are some of the complications of BHRT in women. The progesterone should be given like 30 minutes before they go to bed. Especially if you combine it with maybe 25 to 50 milligrams of CBD. Seems to be very effective if women are having disruptive sleep from low progesterone. And then all women on bioidentical hormone replacement therapy should be on DIM. We talked about this in men. Diindolylmethane, methane, which comes from cruciferous vegetables. It's a natural aromatase inhibitor, and it also drives estrogen down the 2-hydroxy pathway, which is preventive for cancers and so forth. So it's protective for cancers, and it's cardioprotective as well. Very, very important. The other is iodine. You also want to do a baseline iodine. Usually women have an iodine deficiency at baseline if they are going through menopause or already have gone through menopause. And so another reason is iodine will also help drive estrogen down the 2-hydroxy pathway, as will DIM. Which is fantastic. Yeah, progesterone too. We use this in men frequently too, who are having sleep disruption. It helps with sleep. It alleviates anxiety and depression, and it also prevents cyclic migraine headaches, which a lot of people don't know about either. So super important.
And one question that I had is, if women were to struggle with fertility, what is the chance that low estrogen could be the cause of that?
So in those particular cases, that gets to be much more complex, and a lot of times it's not just hormonal. And this is why in cases like that, we'll use drugs like clomiphene to actually try to produce more follicles, get more follicles moving. So it's not always just hormonal in that case. In that case, there's other physiologic mechanisms at play prohibiting them from becoming pregnant. So, The next thing I wanted to talk about too was how do we get the medications in their bodies? What are the delivery systems for bioidentical hormone replacement in women? Well, one is going to be creams, right? So creams we can have done at compounding pharmacies. Some do use a patch. Sublingually, which we can make troches as they pop under her tongue. Very few are on injections. I have a couple ladies that are on tiny doses of testosterone. And then, of course, pellet therapy. And as I think you and I talked about, pellet therapy is my most unfavored form. I know it became a big fad and it's a thing. And people usually say, well, you can go about 4 months, every 4 months, and you don't have to have them done. The problem is this. Pellets being the hormones being released in a static fashion is due to the cardiac output. Okay, well, cardiac output is dependent upon the amount of exercise you're doing, and of course, temperature has a lot to do with it. So if you are someone who uses a hot tub, a steam room, a sauna, hot yoga, and or just going to the gym, and you're increasing your cardiac output by exercising, you could actually burn through your pellets in about a month. So you feel great for a month, and then you feel terrible again. So it's a very inaccurate release system, and so I don't do any, actually. And some people have entire practices based on that, and that's fine. To me, that's more a matter of just making a buck and not really looking out for your patient, and trying to mimic what their physiology actually dictates, because pellet therapy is not physiologic, especially when you become very vigorous in your exercise, are in a very warm climate. Use, again, sauna, hot tubs, and steam rooms and so forth, or hot yoga. So I am not a fan at all. So most of my women are on creams. They're on usually a micronized progesterone capsule at night. And or sometimes in the creams I will put estradiol, and sometimes estriol, which is protective estrogen. I will put progesterone in there so they can take this at night. I will put in testosterone. I will also put in DHEA, dehydroepiandrosterone, which is a precursor to all the sex hormones in the body. It's made in the adrenal gland. So that's those are the delivery systems. The baseline lab tests that the ladies should know about. Usually I'll do a comprehensive metabolic panel, a lipid panel, which will show their cholesterol profile, hemoglobin A1C and their insulin level to know where that's at, and a complete thyroid panel. So I'll do a TSH, total and free, T3 and T4, TPO antibodies, thyroglobulin antibodies, and reverse T3. Vitamin D levels are super important, right? As we've talked about before, vitamin B12 level, total and free testosterone levels, estrogen, progesterone, FSH, LH, DHEA, sex hormone binding globulin, ferritin, and an insulin resistance panel. So it's extensive at first, but you're not repeating that, those lab tests probably ever again. You're dialing in certain things, and then labs need to be done every 4 to 6 months thereafter, once you have people, dialed in well. But I wanted to talk a little bit more about the importance of vitamin D. So vitamin D receptors are found in every single cell in the body, okay? And what they do, from an immunologic standpoint, if you found out during COVID, Ron, I think we talked about this, they increase the function of your natural killer cells, which is your first line of defense against any disease, okay? So they allow the killer cells to spring into action. The optimal vitamin D levels that you're going to want in your body are between 80 to 100. If you look on a lab test, it says 30 to 100. Well, 30 to 100 is a big swath. And what we found was anyone that had levels less than 55 had hampered immune system. So certainly over 55, if we want to optimize, it should be 80 to 100. Vitamin D increases brain function and brain health. And especially if we use it for seasonal affective disorder. So we don't see this so much here in Florida. People that are up in the dark regions and
spend a lot of time up there.
Spend a lot of time, yeah, exactly, in the dark, especially during the winter. Seasonal affective disorder. Vitamin D is super important for that. It's actually used as a treatment for it. So vitamin D levels less than 50 in women, they'll actually have an increased risk of breast cancer as well. So it's protective against breast cancer. Vitamin D increases muscle strength. I think we talked about this, and contractile force when you go and lift something, which is important. It increases apoptosis, so cells that have a lot of debris in them or are not functioning properly. Vitamin D will kind of wipe those out and make sure your body is healthy. And it also increases angiogenesis to good cells. So cells that are functioning well in your body, you will get an increased blood supply to those cells. and it will decrease blood supply going to cancer cells. So one of the treatments you'll see in Dr. Merrick's book, Cancer Care, is high-dose vitamin D. We're using it all the time now. So super important to know about that mechanism of vitamin D as basically a repurposed use for cancer treatment. And we're doing it all the time. Yeah, absolutely. Now, anybody that's on metformin or proton pump inhibitors, so everybody's heard of omeprazole, Nexium, all these, and they're taking them like candy. They get some heartburn and they're just taking them. Just understand it depletes the body of vitamin B12. The other thing it does is changes the acidity in your stomach and also changes your gut flora and your gut health. So we do not recommend them long term. They were originally meant to be given 8 to 12 weeks and then boom, go off of it. So proton pump inhibitors are not something to be taken lightly. They also cause a decrease in calcium absorption, which then leads to osteoporosis as well. There are so many downsides to it, so I'm not a fan of those at all. You want to use them short term, I would say max 8 to 12 weeks, and that's it. And then you get off of them. So more on thyroid health. So if a patient doesn't seem to be responding to thyroid replacement therapy, so most people you'll see are on levothyroxine or Synthroid. I don't give any of that typically. I give either Armour or I give NP thyroid, which are 80% T4 and 20% T3. T3 is really the physiologically active form of thyroid hormone, and it has to be converted from T4. So if a patient is not responding to our therapy, it could be a converting problem. And again, most docs don't test for this. So if you think it's a conversion problem from T4 to T3, you always check the levels of iodine, selenium, and zinc. And I always give those supplements because a deficiency in any one of those will cause a decrease in conversion of T4 to T3, which will then slow your metabolic rate down and make it look like you're hypothyroid, when in fact you're just deficient in either iodine, selenium, zinc, or all of them as well. So
It's awesome. It's cool. It's cool learning a lot today. I'm not gonna lie. One of this episode, I didn't know jack shit about woman's identical.
Oh yeah,
identical hormone.
Yeah, man. There's a lot to know. There's a lot to know. And so some people say, well, look, I've been on Synthroid for 20 years. What if I wanted to change over to Armour or NP thyroid? It's a good question. And so here's how we dose that. So if you're on 100 or 112 micrograms of levothyroxine or Synthroid, that's the equivalent of 60 milligrams of Armour thyroid or NP thyroid. If you're on 50 micrograms, then it's 30. Right? If you're on 25 micrograms, then it's 15. So again, we can always adjust equipotent doses of Armour or NP thyroid depending on how much levothyroxine or Synthroid that you're on. It's a very easy conversion to make. A lot of people don't know about that one. Most docs don't know how to convert that. Really, that should be common knowledge, and now we've just made it common knowledge. We're doing a lot of common knowledge here, which is fantastic. We love to share like this. At a typical starting dose I'll give you a typical dose. So if lady was deficient in all the hormones we were talking about, and I wanted a compounded cream, usually I'd start them on about 0.5 milligrams of estradiol cream, along with progesterone, 100 milligram, testosterone, 3 to 4 milligrams. See, it's a tiny dose, and then dehydroepiandrosterone, DHEA, 5 milligrams. You can put that all in one cream. Some women prefer to take the progesterone as a micronized capsule form, and so I'll put estrogen, testosterone, DHEA in the cream, and then I'll give them progesterone in a capsule at night, and then they sleep really well. Any woman that's taking these should be on a probiotic, and everybody should be on vitamin D3 and K2. Remember, K2 is so important for channeling calcium and vitamin D into the matrix of the bone and also into the medial layer of the blood vessels and away from the intimal layer, so it prevents atherosclerosis. So very important. So it puts you always want D3 with K2, and the amount of K2 you want is 500 micrograms a day. D3 you want 500 international units. You take those together, and you'll get increased uptake of calcium into the bone and away from the intimal layer, so it will decrease atherosclerosis, and put it in the medial layer, the muscular layer of the vessel wall where you want it. And then also I recommend coenzyme Q10, which is a cofactor in your mitochondria, which is responsible for cellular energy. A lot of times, and I've seen this in people with fibromyalgia. Everybody's heard of fibromyalgia. It can be a very distressing problem, and it's more prevalent actually in women. What we find is if you give coenzyme Q10 and PQQ, which is pyrrolidinylene quinone, these are two cofactors in the mitochondria. We usually, when you replete that, you increase cellular energy, and all that pain they were having for years just goes away. So super important to always consider probiotic, for one, increased gut health, D3K2, and coenzyme Q10, about 200 milligrams a day is sufficient for most people.
That was a really interesting topic. I learned a lot today.
I'm glad. It was a whirlwind too. We
Yeah.
went through a lot of material, but in a nutshell, that's kind of how we do it. Obviously, there's any one of these topics. We can always take a deeper dive. We can talk about how the thyroid hormones are all synthesized and everything else. We can take a super deep dive, but this gives you an overview of, as a functional medicine practitioner, how I approach it, how we look at it, and then how we determine dosages and so forth.
I mean, we just did an episode on men's, and now we're doing an episode on women's bioidentical hormone replacement therapy. So if anybody is listening to this and they're interested in any of your services, your website's right on our YouTube page.
Yeah, drmichaeluphues.com. Always feel free to reach out to me. I'm probably the most accessible doctor known to man. Ronnie knows this. Most of my patients have my personal cell, and most don't abuse it. We've had a couple situations over the years where I've had to block, and we had to tell them just call my office because it just doesn't work out. So I do, because a lot of the medicine, to be honest, folks, I do for free. Someone will call me for a Z-Pack, and I'm not one to banter about and make a big deal out of it. Their kid is sick, they need an antibiotic, they need ear drops for a swimmer's ear or something. I'm very quick to call it in, get it done. I don't charge, and it's just how I do things. It's a very old school way of approaching medicine, but that's why I went into this field. It wasn't to become rich. I didn't go to an Indian reservation to get rich. I guarantee you that. You go there because you care about people.
It's an art.
Yeah, it's an art. You care about people, and you're doing it for the right reason, and that's why we're here.
That's it, man. All right, another great episode with you. We got some fucking awesome topics coming.
Ronnie,
up
this
next.
was amazing. Tell them about a few of the topics we've got coming.
Let me go. I got to pull up my notes real quick.
No problem. Ronnie's going to pull those up. It's going to be exciting, folks, because we're going to probably do a couple of these at a time, and then Ronnie will release these as he sees fit here. But he's got a couple of topics we're going to be doing. Go ahead and tell him.
Next, we got physical training, medical marijuana, the opioid epidemic, the history of medicine, a retrospect on COVID, mental health, blood pressure, and an episode just based on you, telling us a little bit about your life, your training, everything in between.
Yes. My times in Barrow, Alaska, up on the North Slope Borough, right on the Arctic Ocean in Alaska. Spent time in Juneau, Alaska as well, and then, of course, the Fort Peck Indian Reservation was quite the experience. That was such great people up there, such great memories, and it really helped make me the doc I am now. It's I owe a big debt of gratitude for folks up there. They really developed me not only as a doctor but as a man.
Awesome. Thank y'all for listening to another fucking awesome episode of The Art of Medicine. Dr. Michael Uphughes at the beautiful Sunshine Supply Kava Bar. Also got a Kava and Kratom episode coming up.
That's right, Kava Kratom we're going to do too. We'll tell you where these plants are from and how they work and so forth. It's going to be a great episode. So you guys stay tuned, and everybody be well. Remember, move every day, get out in the sun, walk if you can, eat whole foods, mostly plants, not too much. Real simple, but to continue to train. Durrani and I try to train 7 days a week. We do something. I mean, even if it's for a walk, 7 days a week, something.
That's it. All right, y'all have a great rest of your day.
Be well.
Nice seeing you, man.